Hello, everyone. Hello, everyone. I'm Dr. Uthra. I'm a consultant diabetologist at Dr. Mohan Diabetes Specialities at Gopalapuram. Good evening and welcome all to this interesting topic on diabetes in elderly. How different are they? So I have few slides to show you initially. Then I'm all open for questions from all of you. Yes, let's see some basic data from diabetes and elderly. So we know in India, there's a rapidly aging population. So we have surpassed the China to become the most populous nation in the world. And the difference between China and us is that we do have a lot of elderly population also and slowly growing population. So they are already elderly. Now we are a growing population. So more and more numbers are going to get added to our elderly list. So if you look at the data from 2022 to 2050, population of India will grow by 18%, and the older people will grow by 134%. And there'll be 279% will be 80 plus. Yes, of course, it is a good news that longevity is increasing, but with that comes a lot of comorbidities or complications and the quality of life of our people. All that also we have to think about, because 24% restriction of daily activities can happen. This is from the Lassie study. And also 23% prevalence of multimorbidity, having other complications. I will deal a little bit about these in my following slide. So when I say getting old, nothing is preventable. Everyone has to get old. There's no way that I can stop aging in any of in me or in you. So aging is inevitable. But what are we talking about when we say about healthy aging or the quality of life of our elderly and so on? It's no way that anybody can stop someone becoming 70, 80 and so on. But what we call is that is a health span versus the lifespan. So what is the lifespan is that from the day you are born, when do you die? From the day I'm born, when I die, that is my lifespan. And what do I mean by health span is that, so the normal health span, and then I develop some diseases and then I die. Now the diseases span shouldn't be too long. So if I can shorten the diseases span as shown in my slide deck here, so the optimal longevity health span and the very minimal disease span. So mortality is inevitable, death is inevitable. But if I'm able to prolong the quality of my life and just have a very short period before I die, with disease span and so on, that is what is called as the health span. So the whole idea of us doctors or all health, health people to improve your health span is by decreasing the disease span and increasing the longevity. So when I say multimorbidity can happen in the disease span, what all diseases? This is data from our own study where we showed that in ICMR INDIAP study, where we showed that the risk of diabetes, pre-diabetes, hypertension, obesity, and abdominal. Not obesity means it could be generalized obesity or abdominal obesity, and abdominal obesity is related to multiple risk or multiple visceral obesity, we call it the central obesity, which has a risk of developing multiple health disorders rather than general obesity. And of course dyslipidemia or hypercholesterolemia, all these are risk factors for developing other diseases also, and all these can affect your health and affect your quality of life. So the number of visits to the doctor, number of pills you're taking, all this is going to depend on these comorbidities. So when we say comorbidities, it's just not the metabolic disorders or what we call, diabetes, hypertension. All what I showed you in my previous are called metabolic disorders. There is something else also we have to consider to have a healthy and then a good quality of life. Cognition is very important, right? So you can see people when they get older, they tend to forget things. They tend to have difficulty in remembering even day-to-day activities, and then understanding things can also get a little difficult when they get older. This is again a natural phenomenon, but the decline shouldn't be too rapid. And there are so much data which shows that in diabetic population, the decline can be much more rapid. That is the cognition decline in people who have diabetes and people who have uncontrolled diabetes. the decline of their cognition if unrelated to the age. So a 60-year-old or a 70-year-old non-diabetic and a 70-year-old diabetic, if you compare, the cognitive decline is faster in a 70-year-old diabetic rather than a 70-year-old non-diabetic, and especially if he's uncontrolled. So thereby, then there are a lot of data which show dementia risk increases, cognitive decline increases, and so on. So that is my to look out for cognition deformities also. And when we say cognition, the exaggerated or the diagnosable state of decline in cognition is called dementia, Maradi Noi, they call it. So this dementia can also happen, but there are a lot of risk factors for dementia. Not everybody develops dementia. Dementia is a premature cognitive decline. And the interesting part with this study is that almost more than 45% of the risk factors for developing dementia is modifiable. Modifiable means preventable. So if you're looking out for it and if you're able to pick it up, you should be able to prevent dementia in our elderly. And when there's dementia does occur or a cognitive decline does occur, where in a diabetic population, it's kind of a little difficult to handle. With dementia and diabetes side by side becomes a vicious cycle. Because of diabetes, dementia can worsen. Because of dementia, diabetes can worsen. Vice versa, it goes on like a vicious cycle. So when dementia people forget to take their pills, forget to go for checkup, and thereby the sugar levels increases. And because of the sugar level increasing, dementia, worsening of their memory, worsening of their behavioral nature, mood swings, and all that can worsen. So it is very important that both of these are controlled simultaneously. So when I said diabetes in elderly, what's so majorly different from the non-elderly population is that their complication risk itself a little different from the non-elderly population. So cannot one size does not fit all. So here in the elderly, as as diabetologist, I would look into more, give more weightage on to the multiple comorbidity. So is my patient who's sitting in front of me above 65-year-old, is he having multiple drugs, or how much pills is he like eating pills in bunches like 12 to 14 tablets. So I'm going to look into each and every tablet which my elderly patient is having, and it's definitely necessary for them. That is called the polypharmacy. So because as you grow older, some of the preventive medicines might not be necessary. So in a forum like this, I cannot say which should be avoided, which shouldn't be, but definitely we have to pay attention in an elderly to the number of tablets they're taking, because many of them can interact also. Then if they're on other complications like heart disease, all that I have to look into. And frailty, very important. We've also done a study in our center where we looked at frailty, because we can't cluster all elderly as one. You've known you might have you might be 65 or 75. You will have friends who are of your same age, but they might not be as active as you are or as healthy as you are, but the same age. So not all age is just a number. So the quality of life or the comorbidities present in that person will worsen the health picture, or the health span of the person. So thereby frailty is one of the very important factors where we can make the difference between two elderly, whether the person is frail or non-frail. Then we can decide on the treatment modality, and also risk of hypoglycemia. So if you ask which is more important, hyper or hypo in an elderly, both, but the immediate risk would be with hypoglycemia. So thereby I would definitely be cautious when I am prescribing medication to my elderly to prevent hypoglycemia, because hypoglycemia can lead on to heart attacks or multiple complications. So it is preferable to avoid hypoglycemia in the elderly, especially the frail elderly. So that's why the picture is kind of little different in the elderly than the non-elderly population when treating diabetes. So we have a lot of governing bodies or guidelines like the ADA, EASD, RSSDI, and so on, which we constantly keep updating our knowledge on about treating elderly. So here we cannot cluster, as I said, all elderly into one basket. So it is the older adults with good health, older adults with intermediate health, and older adults with poor health. Accordingly, we set their targets. So we set the target for the blood sugar, we set the target for their blood pressure and activity level, physical activity level, diet. Everything is based on the the category. So older adults with good health is people who are functionally and cognitively intact. We've known so many of our my senior doctor colleagues and so on who are 80 plus still practicing, 75 plus practicing, or even yoga masters, or even other professionals who are 75, 80 yet functioning with their full capacity. So these group of 75, 80-year-old would be considered as a functional and cognitively intact. So we expect a longer life expectancy. So we try to keep the A1C goals as strict as possible. But people with intermediate health, they are functionally dependent. So they have multiple, coexisting chronic illnesses. So they might have multiple burden like diabetes, hypertension, dyslipidemia, maybe a cardiovascular event or a stroke or so on. So when they have a multiple event, they come under intermediate. So there we have a little relaxed target. Older adults with poor health, they are severely frail, bedridden, wheelchair ridden after a fracture or after some cancer treatment or some palliative care or on dialysis or so on. So end stage chronic illnesses, then we avoid reliance on HbA1c and focus on preventing hypoglycemia and symptoms of hypoglycemia. So it is more or less a day-to-day picture. We kind of have it in a severely frail elderly population. So that's how we do not cluster all elderly into one, and we try to have a tailor-made plan for each of our elderly diabetic. So when it comes to the diabetes management and when it comes to prevention, because we do know that diabetes per se can have a high risk of gaining infection, so can catch up a lot of infection, and in elderly it can worsen immediately. Just a small infection, they would have been fine the whole period, and then just one infection after that, suddenly the health deteriorates. So thereby we are a little cautious with the elderly. We do not want them to get any infection. So what are the vaccinations we can think of in the elderly? Influenza vaccination is very safe to be taken every year by the elderly. Yes, you are 75 plus or 65 plus, or all age groups can take influenza. Pneumococcal vaccination, this is advised in people above 50 years. Hepatitis B vaccination is also safe in elderly. Herpes zoster vaccination or the shingles vaccination, because of late we do see a lot of shingles patients excruciating pain because of shingles. It's also called Aki in Tamil and various other languages. Herpes zoster infection, which can lead on to a lot of pain and complications. Sometimes it can happen in the eye or ear and it cause a lot of problem. Thereby, shingles vaccination, again, this is approved only in 50 plus, and 2 doses are necessary, and it's once a lifetime, 2 doses once a lifetime vaccination. So these are some of the vaccinations. If you are an elderly, or if you have elderly parents or relatives at home, you should definitely recommend for our elderly population. And there are a lot of technology which can help our elderly, asking them to prick their hand every day, make a blood sugar note down and keep their blood sugar, which might not be possible to do that tedious work after a certain age. That's why we can use of technology like the CGML. It's a small sticker, most of you might know. There are two types. One is you can bring it to the doctor, get the reader and take a printout of the blood chart, or you can see it on your phone itself. So the no prick, no blood, no mess at all. It can be seen in any of your smartphones. And I have patients who have installed CGMS, and the phone download in their sons or daughters who are staying abroad or somewhere, and they can very well see the blood sugar levels in their parents. So that's kind of, the technology is so advanced and newer things are coming in, which are definitely going to help our elderly population. There are also smart insulin pen, which are Bluetooth enabled, so that they can calculate the dose, because sometimes the visual acuity can be a issue. So a lot more. Just a few of those I've shown for one of time. So much more, and especially in an elderly type 1 diabetic, and giving 4 shots of insulin and so on could be difficult. So there are CSI pumps, so insulin pump, which can readjust. We can have a programmed delivery systems can be thought of. So this will have a basal and a bolus dosages can be adjusted and through a smart system and so on. The pump is so much developed these days, and incorporated the CGMS and so on, which can also be used for our elderly. So thinking of all the complexities in our elderly population, So not all diabetic population can be categorized as one. So we wanted to do something more for our diabetic elderly, give a more specialized care. That's when the previous World Diabetes Day, Sir Dr. Mohan sir had initiated two projects. One is healthy aging, and other is Dr. Mohans on Wheels. The healthy aging is basically to create awareness about the elderly, how to have a healthy aging, that is the quality of life, improve the quality of despite diabetes, how to be healthy for a and to have a healthy health span. So this is basically to give a holistic multidisciplinary care for our elderly, where we have to consider cognition, dementia, depression, and frailty also. So we have specialized team with psychologists, psychiatrists, and neurologists who will look into all of these aspects along with the metabolic care. And this is basically to improve the quality of life of our elderly diabetic population. So tailor made to each of the diabetic elderly population. So in this healthy aging clinic, we have multiple aspects. We look into diet is a very important part. So we have a separate dietitian who will give diet charts tailor made to that elderly who has different needs. So not elderly, as I said, can be clustered as one from Dubai will eat a little different from one from Kakinada or from Kanyakumari. So each of them, their needs, their multimorbidities, all this will be looked into. Even simple things like a denture can make a difference in the nutrition. So all this will be looked into by a specialized dietitian. Physical activity again, which is most neglected in the elderly. They say, I'm already old, why do I need to exercise? That should definitely, especially resistance training and all that, gradually. So you can't just jump to exercises and so on. That will also be given tailor-made counseling sessions, detailed counseling. We have a senior psychologist and also a psychologist for our healthy aging specifically, who will help us with counseling for their depression or mild cognitive impairment and so on. We have yoga therapy, music therapy, art therapy, and of course, we have specialists like the psychiatrist and neurologist taking care of the medical management, along with the standard of care of the metabolic health, maintaining diabetes, blood pressure under control, cholesterol under control, and other complications all have been looked into in this format of healthy aging clinic. And that is why what we aim at is that we've already published this is data from our center, which shows that long-term survivors with type 2 diabetes had better glycemic control and blood pressure control and more favorable lipid profile. It's not that if you had diabetes for a long term, your sugars cannot be under control or your other morbidities are not under control. With effort and proper planning, definitely the your optimal health span can be prolonged than along with your lifespan. So it can be the lower down bar can be definitely achieved. So what you have to do for that is that make sure that your health is your responsibility. Even if you're dependent on your children or dependent on someone for your monetary benefits or buying medicines and so on, but still your health is your responsibility. So know your medication schedule, how to administer medication. Don't if possible, don't depend on others for knowing your medication. Know your diet plan. What is your usual diet plan? What is the benefit of it? Motivate yourself to do physical activity, even in a small way possible. Get medical attention if there are some cognitive issues. You're forgetting things, you're repeating things, and your understanding is coming down. Don't hesitate and don't consider it to be a part of normal aging. Sometimes, most of the time it will be, sometimes it might not be. So get attention. Remember to consult your doctor regularly, because your blood sugars, even in any age group, will keep fluctuating. But in the elderly, it can fluctuate even more. So, one time the doctor gives you a prescription, it is not necessary the prescription will hold on for the next 1 year. You might have to keep readjusting the dosage of your medications according to your need, which can keep varying over periods of months. So try to stick on to the review schedule, and sometimes the medicines need to be reviewed, adjusted, and most of the complications are asymptomatic. So we have to pick up the complications before you start getting some symptoms. So by testing, if you're picking up a small microalbuminuria, by just testing your urine, then definitely you can prevent dialysis and so on. So we don't want to go to the doctor and check when it is a stage when the urea creatinine is so high that only dialysis is possible. So picking up early can definitely prevent a lot of complication. So youth is a gift of nature, but age is the work of art. And I think with a little effort and joint teamwork, your aging could be definitely healthy. So I stop here with my presentation as such, but we still have time to take up questions, and you can start posting in your questions in the chat box. Let me open up to see if there are any chat questions already. Okay, so there's one question: how to overcome body pain if we have a diabetes? Okay, body pain could mean a lot of things. It could be lethargy, or if you had a recent infection or something, then you could have body pain. So look at your sugar levels. The symptoms of hyperglycemia. One of the symptoms could also be that lethargy, feeling dull, no mood to do new things, increased urination, increased thirst. All these could mean high sugars also. So definitely get your blood sugars checked, and look out for what other signs do you have, and make sure that you're having a good sleep, hydrating yourself, and exercising. No exercise, also no stretching or no exercise, can also make your body feel little tight, and pain can also be there. Is there any further questions? The usual common question is about the HbA1c. So they usually are in an elderly, can we just relax the HbA1c and not necessarily 6.5? So that's why I showed that slide. We categorize them into three different types, that is functionally able, intermediate, and severely frail, and so on. Because the HbA, again, even saying that, it's very, very individualized. I have 80 plus men who do have a 6.5 HbA1c, and without hypoglycemia risk after a CGMS and so on, who are very active. So tend not to make too many changes and let it go like that, and they're very comfortable with 6.5. I don't try to increase it to 8.5 and so on, but it's very, very individualized. That usually in an elderly, it's a little relaxed. A1C targets are a little relaxed, but it is more about the balance rather than fixing a target. So now with the newer CGMs and all that available, we are moving towards the better glycemic variability, not to have too much fluctuation. So having a 70 and then a 300, there's too many fluctuation to be avoided. That is what we try to enhance. Okay, there is more question. What are the parameters if elderly have kidney problem? Yeah, I think that is when we say when there is a comorbidity, then the whole picture changes. So diabetic with a kidney problem, yes, again the water intake, depending on the kidney problem, again it's an early stage or a little advanced on dialysis and so on. It will vary. So it has to be tailor made to the patient. But what happens in a kidney problem is that in a very severe kidney problem, the blood sugar levels are not that high. So usually, if there is a kidney problem, insulin is the treatment of choice, and most of the time, your doctor will adjust the insulin dosage according to the blood sugar levels. And if the patient is on an end-stage renal disease, like on dialysis or something, then usually it is a very small dosage of short-acting insulin would do. Many of the tablets, or what we call as the diabetic pills, are not safe in a severe renal problem patient. Again, with liver problem, heart problem, and so on. Heart problem, I think one more question is that about heart problem is that if there is a heart problem, the hypo risk should be a little cautious. But again, it is a balance, and they are on a lot of medication So you'll have to make sure there is no interaction, and the timing of the medications and all that is clearly denoted to the patient. You can type in your questions so that it will be more interactive. I try to keep my presentation short because depending on the viewership and the questions, I thought I could answer your doubts. About exercise, yes. When we think about exercise and elderly, again, definitely exercise plays a very important role. So, with even every elderly should exercise, and the intensity or the type of exercise will definitely depend on the comorbidities or the other problems the elderly have. There's another question. It says, I'm having digestive problems nowadays. Does aging have any effect? Yes, aging definitely impact the digestive system also. So as you age, the enzyme production, the production, all that definitely declines to a certain extent. So it will definitely have an impact. Aging has an impact from head to toe, all parts of our body. So the interesting part is the process of aging doesn't start only when you are 80 plus and so on. It is quite gradual. After 18 itself, this process of aging starts in. So how rapid it is, or how are we going to slow down it, is this the question. So digestion can also be improved with good quality of food and exercises. Exercises will improve the blood supply to your brain, blood supply to your gut, and thereby exercise per se can improve your digestion. But however, if there are any other reasons, in the elderly, there are certain digestive disorders or which are also quite common. That has to be looked into. And if your diabetes is not under control, diabetic gastroparesis, that is also quite high in the elderly if the diabetes is not well controlled. And there's another question which says how to identify insulin resistance and insulin deficiency. There are more and more scientific and intelligent questions coming in our forum. So insulin resistance and insulin deficiency. So when this is the diagnosis of type 2 diabetes, so where there is a secretory disorder and a resistance disorder. Insulin resistance is quite interesting, and it's gaining more and more importance in all fields because that is kind of the pathogenesis for multiple complications. So insulin in a common man, how to diagnose insulin? There are a lot of clamp studies and all that research-based studies, but we're not in a common conversation. Insulin resistance can be picked up by something called acanthosis. That is a dark skin tag or darkening of your skin over the nape of your neck or underarms or in your folds of your skin. This could mean the person is having insulin resistance. Obesity per se, it's a sign of insulin resistance, and fatty liver or fat deposition in the liver, hepatocyte. That can also mean insulin resistance. But there are, like the HOMA IR and other tests which will show insulin resistance. Secretory defect, again, developing diabetes per se could mean there is a definite reduction in the secretory defect in the pancreas. There's a test called C-peptide. It is a blood test. 2 samples are needed for that. That can tell to a certain extent how is the secretory capacity of your pancreas. And next question is ideal body weight to be maintained. Yes, so ideal body weight depends on the height of the person, age of the person. That is how we calculate the ideal body weight. Now, earlier, the BMI we used to say, that was considered as the index for obesity. Now, more and more things, the waist height ratio, then the DEXA scans, the densitometry, or the fat thickness, all these became more popular with diagnosing obesity. And any relation between stroke and diabetes, definitely that's a very important question. Yeah, there is so much to speak about it, but to keep it very short is that diabetics have a very high risk of developing stroke. So when I say a stroke, remember I was talking about cognitive decline and mild cognitive impairment, dementia, and all that. When I say dementia is a umbrella term. There are a lot of things under dementia. One of the commonest you must have heard is Alzheimer's dementia. So Alzheimer's disease, Maradi Noi, they call it. So that is the commonest dementia. But there's also something called vascular dementia. Vascular dementia is more common in diabetic population. So what is vascular dementia? It is mini strokes. So it's like small strokes happen in your brain, and thereby memory loss and all that. So that is called vascular dementia, which is also, even without vascular dementia, any form of stroke is much more common. Even TIA, all that is much more common in the diabetic hypertensive. The risk increases even further. And there's a question which asks, what is the recommendation on diet? I was expecting this because I didn't mention much about diet. So when medication, HbA1c, exercise, everything has to be tailor made. I think a diet definitely needs to be tailor made. So the one of our previous viewers had a question, in CKD what happens? So when there is a CKD, again the diet is going to be totally different. So they have to have a salt restriction, fluid restriction, and so on. So if you're just if you're a diabetic elderly and you do not have any comorbidity, so it is a normal healthy diet according to your BMI, according to your weight and recommended weight. The calories will be calculated, and what is special, what has your special attention you need to pay in your diet is that I would suggest have a small frequent meal, and then increase your protein, because elderly tend to neglect their protein. And if you see the elderly, the muscle loss is also quite common. There's a term, medical term called sarcopenia, which happen naturally also, and sometimes can be accelerated, fast forwarded in the diabetic elderly. So to prevent that, only two things possible. One is resistance training. What is resistance training? Small 2 kg, 3 kg dumbbells you can buy and do simple exercises, preferably under guidance initially, but otherwise also simple resistance training exercises and good protein food. Then again, protein, most of the elderly diabetic can take it, but in a CKD, you will have to consult a nephrologist before you increase your protein. And of course, antioxidants also. So take a lot of nuts, fruits if allowed. If your HbA1c is under control, then fruits is a very good, fruits, vegetables, nuts, which will give you a lot of fiber. So fiber and protein, pay attention to, try to increase it in your daily requirement. And yes, there's another question on how to digestive discuss that. Diet for elderly is, and it's a huge topic as such, and but it has to definitely be tailor made. And exercise for elderly, again, it's very important, shouldn't be neglected, and that also has to be tailor made. So that's when we look at something called, the muscle mass. To look at it, we do something called the hand grip measurement, which will show the how is your strength in your upper limb. So we do it as part of our healthy aging clinics. Any further questions, or we can wait for another 5 minutes and then we can call it a day, I guess. Yeah, so compliance, again, one very important. Many of the elderly diabetic, they tend to forget to take their medication, and sometimes they overdo it also. So instead of I forgot to take the tablet in the morning, doctor, so I just took my morning tablet and the evening tablet together. That usually is not recommended at all, but in an elderly could be totally dangerous. Okay, so never ever do that. Trying to take your day medicine at the night, or your doctor would have prescribed you a particular set of medication in a particular order and format for a for some assured medical reason. So you cannot take your morning pill. And I've seen this with insulin also. So I suppose I give them 18 units in the morning and 10 at night. sometimes they say, I just took, total together was only 24 units or something, and I just took 12 and 12. I just divided it into two. Don't do that way, and definitely follow the advice, because there will be a particular reason. And in elderly, this can be very, very detrimental, can cause severe hypoglycemia and unrecoverable. And when in severe hypoglycemia can develop fits and so on. The thing about memory, yes, the thing about memory is that, yes, as people age, or elderly population, definitely there is a decline in memory. But what we have to, the warning signs or something is that if it's happening too repetitively, if it is too rapid, also, forgetting things once in a while, why you entered a room, you forgot why you entered the room, searching for what, that is okay. But if it's happening too often, or if you're being too repetitive with things, if your mood swings are too much than usual, then you definitely, it's preferable that you get an assessment done, a cognitive assessment, we call that. We do have a lot of tools which are non-invasive, and that can really pick up whether there is some warning sign like an MCI, mild cognitive impairment, or dementia or depression, can be picked up much, much earlier. And in the MCI stage, most of it will be preventable also with CBTs or cognitive behavioral therapies and so on. You can type in questions for another 3 to 4 minutes. So it's been almost joined at 5. It's been a good interaction so far, but I can still take a few questions. So feel free to type in any questions, however important or silly you feel the question is. There's a relation between the another question is about whether the relationship between stroke and diabetes is reversible. That was one of the part of the question. So what do I understand from being reversible? It's a stroke, recoverable and so on. The treatment of stroke and the to prevent the neurological deficit in a stroke, timing is the most important, and the intensity of the stroke also makes a difference. So if you're able to identify the stroke quite early, and get the necessary medical management is done immediately, the recovery is almost complete in many of the patients. But in an unfortunate few, it might be there might be some residual neurological deficit, some mild deviation or mild loss of function and all that. But with the newer physiotherapies and stimulation therapies available, the scope of improvement without affecting your day-to-day activities is also quite possible in these days. So there is a lot of interaction with more of good evening, thank you, and so on. So I think since there is no more further, I don't see much interaction there in the chat. So it was a pleasure speaking to you all this evening, and I hope this short presentation and discussion was useful to you all. And for any further queries or any further discussion, we are always open. You can type it in our Dr. Mohan's. One of the handles. So many of the handles have been listed here. So one of the social forums, you can post in your queries. You can, if you think of anything new. So thank you all. Bye bye. Have a great evening.